Good afternoon, everybody. So, this is a integration class. You have done that HIV, I think 2 classes were done, right? 2 lectures and also practicals on HIV. But even though CBME has put this topic of HIV under integration. So, according to that, we are from phase 2 faculties, myself, and also we have faculties from phase 3, from medicine department, from pediatric department, and from psychiatry department. We will have faculties today who will also discuss about their aspect of HIV. Okay. So that is what is our topic today. And for you people, it's very important as far as exams are concerned. You may get questions on practical theory questions, and also for your clinics. Throughout life as HIV, you know, there we have got so many cases. So you may come across them in OPDs, in IPDs, or in emergencies. So the whole intention is to prepare you if you come across a patient, how to deal with the patient, right? It's not only learning theoretical part of the HIV, you have to know the practical aspect, how to go about it, what test to be done, how to do it, whom to refer, all those things. Okay. So, HIV is human immunodeficiency virus, all of you know. So, once the virus attacks our body, the immune system, the receptors are CD4 receptors of the T helper cells, we say. So, those specific cells are attacked, and when that cells are attacked, what happens? Those particular T helper cells are responsible for the immune defense system of our body, right? So, our immune system is down, so then all bacteria, viruses or cancers can easily proliferate in our body, right? So, that is the whole mechanism what happens. I will not go much in details, but I thought I will finish up the laboratory diagnosis part, little bit about the NACO guidelines and also the algorithm of the testing protocol, what is practically done, okay? So, here you can see how different organs of the body are affected. The brain, pulmonary, the lungs, liver, GI tract, skin, then tumors, renal, cardiovascular, oral and eye. So, a patient may come with any of the manifestations to you. Okay. So, today we will have a multidisciplinary departmental discussion. General medicine will discuss about the age defining illness, the staging, initiating, ART, antiretroviral therapy and management part. Microbiology will focus on diagnostic algorithm as per NACO and prognostic test during the ART treatment. Pediatrics department like vertical transmission, perinatal infection management, prophylactic, when to do the prophylactic for the newborns, feeding options and monitoring growth milestones in HIV positive infants. Psychiatry is a very important role, has got a very important role for these patients. The mental health, coping mechanism and adherence, pre and post test counseling part. Discussion points may be depression, dementia, social stigma, because HIV till today carries a big social stigma, how to deal with it, and counseling for lifelong medication adherence or drug compliance. So, over and above, I think these will be the topics of discussion as far as you are concerned, like how to approach a patient, that is most important. If you get to see an emergency or IPD or OPD or in your clinics, what to do if you get a patient of HIV, whom to refer, what all to look for, where to test, where to send the test, first test, second test, what to do, right? So, little bit about the statistics, if you know, then only you can understand the gravity of the situation, where we are, what we are dealing with, right? So, first in the list, country wise is 78 lakhs is South Africa, Okay, they are the 78 lakh people who are living with HIV. This is a huge amount, huge number of people, right? Second in the list is India, so we are not very much behind in this. So about 25.61 lakhs people are living with HIV. Okay, and as doctors, we have to be very careful that you have to follow all the preventive measures or the standard protocols when you're working in the hospital, so that you don't get finger prick or any procedure you are doing, you don't infect yourself. Those things are also important. Okay, for hepatitis B, HCV and HIV, 3 viruses which anyone can get if in the hospital. This is also an occupational hazard, you can say. So second highest is India, 25.61 lakhs. Now HIV statistics in Tripura. So whenever you listen to any of the news like regarding statistics of HIV in India, this I have seen that Tripura news is always there. These days, only I think last 2 years, we are seeing that Tripura is also included in that, right? So it's very unfortunate. When I came to Agartala, I think Tripura 10 years back, the scenario was not like this. So now we are getting a lot of patients who are having HIV. Amongst them, the most unfortunate is young boys and girls from the school. Girls I will say less, but young boys, school, high school or college, university, who are into drug addiction, intravenous drug abuse. Okay, so they are sharing the needles, and that's how they are getting the HIV. So this is really a very alarming situation. In Tripura, statistics is 2007 to October 2025. During this year, we are getting already registered cases are 10,876. And people who are under ART means antiretroviral treatment. Okay, their number is also quite high, about 6,417. Tripura has a population about 36 to 40 lakhs population maybe. So this small population also has got so many people who are under ART treatment. So data indicates that many patients in Tripura are diagnosed at advanced stages. So this is very bad. You know, early diagnosis is very important. We need to, why? Because they may have transmitted less, right? If you diagnose late, by that time they have transmitted the infection to so many other people. So in Tripura, it is very unfortunate that because it may be due to less awareness, or people may not be, willing to go to the ICTC center. Even then you send them, but they will not go. They will not take the medication. So that is like less. This is more alarming. So diagnosed at an advanced stage with a significant number of cases showing low CD4 count. Because when you come at a later stage, the CD4 count will obviously go down, indicating late treatment initiation. So NACO, you should know this NACO. What is the full form, okay? They may be asked in your exam. So it's National AIDS Control Organization. There is the body organization which has control of running this whole HIV prevention or diagnosis, treatment, everything, okay? So this uses targeted intervention for high risk groups including free antiretroviral therapy. So the ART treatment, once a patient is diagnosed with HIV, he has to take a treatment lifelong. So this ART treatment is free of cost from the government, okay? So that you have to tell your patients, so that he is willing, or else if he has to pay for that medication, he may not go for the treatment also. And also for the HIV testing. So HIV testing anywhere in India, it is free of cost, okay? The goal is to reach 95% of people living with HIV knowing their status, 95% of those on treatment and 95% with suppressed viral loads. So this is the goal of NACO with which they are working. High risk groups include, who are the high risk groups? Includes female sex workers, men who have sex with men, and injecting drug users are prioritized for targeted interventions. So coming to the lab diagnosis, in short, I will take, because already 2 main classes, theory classes are done with you. in details about the lab diagnosis and also practicals we have done. In short, what is to be done is positive HIV status raises ethical, these things are very important, ethical, legal and social issues. Okay. We have social stigma, ethical, legal and social issues. When testing for HIV, ensure written consent. It's not verbal consent, it is written. You have to take a written consent from the patient explaining that I am going to do your test for HIV and you have to give consent. So he has to sign on that paper. Okay. So that is important. Confidentiality. If you get to know his HIV status as a doctor, you are a healthcare worker, you are not supposed to disclose to anyone else, only to the patient. Okay. So that is confidentiality. Pre and post-test counseling to inform the patient. So you have to do a pre-test counseling and also the post-test counseling. After the test results come also, you have to disclose the result to him, you have to tell the consequences, where to send him, right? What is the, you have to show him the road. Okay, this is the result, now what to do next? And I think details about the counseling part will be taken by Dr. Anirban. He will also talk in details, right? As per NACO Guidelines 2024, we have, this is NACO Guidelines. NACO has, set some guidelines. There are so many tests you can do, but you have to follow these guidelines while doing the test. You cannot do anything on your own, for HIV at least. So what are the guidelines? For rapid test, we are doing the diagnostic purpose. So for finding out whether a patient is HIV positive or not, we have to do a few tests. So in this we have rapid diagnostic test that is done for the antibody detection. So you can do two things, either the antibody detection or the antigen detection or the viral detection, right? For the antibody detection, you need to do this rapid test. We have got three types of principles which are used for this rapid test: dot immunoassay or immunochromatography by the lateral flow and immunoconcentration. So these tests which you will be performing in a lab has to be NACO approved, those particular kits. You cannot do anything on like, ye kit aaya hai, sasta hai, kar lo, nahin. Because again it has lot of legal implications. And NACO recommends the use of rapid test kits which detects 100% of all HIV infected individuals, like 100% sensitive. It has to be, okay. Next, what is the benefit of this rapid test? Screening assays are fast. So if patient is sitting in your OPD, you are just doing the test, within 30 minutes you can give the result. This is fast screening test, rapid test result. You have to give faster, and it doesn't need much expertise. Like you have to know, for ELISA you need expertise. Anyone can do it. So that is the benefit of this. Sensitivity must detect all positive sera, so 100% sensitive. Confirmation results require confirmatory test. I will show you the algorithm, how you go for the confirmatory test. Antigens, which are the antigens that are used? So you have seen in your practicals, na? All those card tests you have shown or not? Say yes or no. Okay. So those cards have got the antigens impregnated in it by the company. So we are looking for the antibodies in the patient serum, right? So if the antibody is present, then it will show the indication, it will show either a dot, if it is dot immunoassay, or it will show a band, right? So that is the way it is done. We have got antigens for HIV-1 and HIV-2. So these are P24, GP120, GP160, GP41 for HIV-1. For HIV-2 is GP36. Detection, identify HIV-1 and HIV-2 separately or together. Few kits have got like only HIV they will show. Some shows HIV-1 and HIV-2. Different kits come in different ways. And these days we also have kits for HIV and syphilis also. It shows whether the syphilis is positive or not. So you can again, there is added advantage because this syphilis also transmits to the blood, right? So if you are screening a patient for dialysis, you can, those hemodialysis patients, so you know that this particular patient is having HIV positive. So along with that, sometimes it happens, when we are getting cases like this, patient is not complaining anything, or he is HIV negative but he is having VDRL positive, So that is how kits have been made these days, so that you detect two viruses, diseases together, okay. So that is also there. Next comes about the enzyme linked immunoabsorbent acid, the ELISA. ELISA, the principle has been taught to you in details. Here I will emphasize where the ELISA is done. Here ELISA and why it is done. ELISA is the most common test so it is done in the blood banks. When you have to do lot of samples together. Suppose there is a blood donation camp. Now you have to do maybe 25, 30, 40 donors you have to screen at a time. So then this ELISA becomes easier, okay. So ELISAs are now done more in the blood banks. And also the P24 antigen also can be for 4th generation ELISA. We have got now which the ELISAs that are used in our blood banks are 4th generation ELISA. In this, the P24 antigen is also incorporated. So you can find out detect it even in the window period. Okay, we'll go and see the window period thing. The graph is there. So if you can detect a patient in the window period or the early detection is done, so the donor, if you are taking blood from the donor, so okay, this blood is not okay for us, right, to take. So it's very important for the donor, whoever is doing the screening, they should use this kit for detection of the P24 antigen also. So it detects as early as 2 to 4 weeks after the exposure. So these things will be asked in the exam. So when P24 antigen is coming, when the antibodies will be rising, or in our viva also. So when is the virus detected? What is the use of the virus detection? So we have to know all those things. Okay. Then Western blot, this is another test which is again a sort of confirmatory test which can be done. Viral RNA detection. Now this viral RNA detection is a gold standard, okay. If anyone asks you which is the gold standard for HIV detection, this is the answer. Viral RNA detection confirms the HIV diagnosis. What is the utility of this? It's most sensitive and specific test. RTPCR is used for this viral RNA detection in the newborns below 6 months. So what happens is, in the newborns, they cannot, their immune system is not able to make the antibodies till 6 months, minimum 6 months. So how are you going to, which test you will use for those patient groups, for those newborns? So this is the answer, okay. We are doing the RT-PCR for the viral RNA detection. So in Tripura we cannot do it, we send it to, this is our regional laboratory, Imphal, okay. The sample is to be sent to Imphal. So this is the viral RNA detection. And again our pediatrician will talk in details about it, when to do, what to do and details. Then is the prognosis test. Now ART, when you have detected the virus, the patient that he is having the positive, right? Now you send him to the ICTC center. There he has to undergo certain test, prognosis for the prognosis, and he has to, just to be decided the antiretroviral treatment, and that treatment has to be again monitored, whether it is the drugs are working properly, the patient, how is the CD4 count after the treatment. So that is the antiretroviral therapy. When it's going on, you have to see the CD4 count, okay, and also the viral load. You have to measure the viral load, which quantifies the HIV in the plasma, which helps to predict the speed of the disease progression, or he is having an multi-drug resistant or not strain. Okay, so all these things will be required for his treatment purpose when he is in the treatment. Next comes about quality assurance. All HIV testing laboratories, they need proper quality assurance, has to be assured. That is, every laboratory should have a quality assurance program in place to continuously assess and improve the process integral to the production of the laboratory results. Reagents and equipment performance must be monitored over time to detect any changes in the quality and in the integrity. So the technician, the lab, the reagents, the instrument, if you are doing ELISA, so all those things has to be monitored time to time, and you have to also run some controls, positive controls, negative controls, to say, okay, whatever testing I am done, that is perfect, or it is okay to be given the result. Now I will go for the algorithms that is useful for for knowing what to do with your patients. Suppose you have a patient with blood, this is donors, okay? Blood donor or transplant donors. So what to do? This patients will, this will you get in the, like in the blood banks or in a hospital. The scenario is like a donor comes, someone from your family or something, a patient is admitted in the hospital. Now you need one unit of blood. The donor comes, 2-3 donors come. There will be some screening for the donors. Okay. So one of the viruses is HIV virus, which will be screened for. So if that first test, so here we are doing the screening A1. A1 is the first test, one test, single test. It may be, usually it is ELISA in the blood banks. So first test positive, what we do? This is one scenario, another is first test is negative. First test negative means he is okay, his blood can be taken for giving the blood, for the blood transfusion or he donation, okay. So he is fine, but what about this positive? If one single test is also positive, we will consider this blood as he is not okay donor, we cannot use his blood anymore. So he has to be notified and he has to also go and see the ICTC center for further investigation or treatment. You have to consider him as a HIV positive person, you cannot take his blood, okay. So, and you have to discard the blood in a proper all the segregation, how to do it, so that you have to process properly and discard it. This is for the blood and transplant donors, only one single test. Next is, if you are doing in a clinically symptomatic individual, suppose a patient comes with tuberculosis, or he is having some fungal infection and you suspect he is cachectic, you suspect that this patient in the hospital, he may be having HIV. So let us look for him. So what is the algorithm here? Algorithm is first test you do. Test number 1, you will do it here. Maybe in your Santiniketan, when you start doing test, this will be the test done here. And then you have to send the sample. If it is a OPD patient, you have to send the sample to the ICTC center, that is in AGMC. We have got ICTC center there. So you have to send the sample there. Okay. And you have to basically, they will do this following test for the confirmation. So here what test we are doing? Screening test. Please, all the students here, be attentive. This will be asked in your exam. If I am having a Viva, taking Viva on HIV, all these things will be asked. Because you have to deal with those cases. Okay. So, so this interpretation is what? You send him to the ICTC center, they will do the following test for the confirmation. So here first one is the possibilities are, or scenario can be this is positive or it is negative. If it is negative, report negative. If it is positive, do another test with another principle. Okay, so it becomes plus, and here you have the scenario is either first test positive, second test positive. So you report both these positives, report positive and post-test counseling. Okay, so this is one scenario where both the test, first and second, both are positive. Okay, now another scenario is first test is positive, second is negative. Okay, then you have to do the third test. Okay, so then we have another, now what can be the scenarios? It can be first positive, second negative, third positive. Okay, that is one interpretation we have to do. In this we say it is indeterminate. Okay, we cannot come to a conclusion or inconclusive. So here we can see two tests are positive, one is negative. Means either there is some issue with the phase of the infection, at what stage the patient is. So in these cases, we will ask to repeat the sample, ask the patient to come again after 18 to 28 days to 30 days. So we have to follow up the patient, you have to counsel the patient. You have to say, okay, this you are having high risk behavior, you may be having, there's most chances for you to, transmit the disease. So you have to take all these precautions. Okay, so you have to explain to the patient. You have to explain and then you have to send it back home. But again, keeping in assurance that you will come back for a repeat testing. Okay, Next is, another is, first one is positive, second one is negative, and third one is also negative, means two negatives. So in this also we will report him as negative, but we will ask him to follow up again. Okay, keep a follow up with us. Next is the, in the general population, suppose any one of us wants to do a HIV testing. So what is our algorithm, how the testing is done? So first test is done here, first test positive, go for another test, second and first is positive, go for third test. So all the three positive report positive with post-test counseling, okay? And first positive, second positive and third negative, same indeterminate, and first positive, second negative, third you have to do again. So first positive and third positive and second is negative, indeterminate. First positive, second negative, third negative. So only one is positive. So high risk, what is mean high risk? Consider indeterminate, or low risk consider. You have to talk with the patient. You have to counsel the patient to get to know about his behavior, what are the reasons that one first test is positive, why at all. Maybe that decision will be taken by you only, what to do, like to get him for again retested next time or not. So you can understand it's like a flow. So there is a protocol by NACO which is set and you have to follow that. So here is the window period I was talking to you. This is a very important statement. In an exam it will be asked, what is window period? What test will you do during window period? Okay, so you have to answer. The window period is the entry of the infection until the antibody detection. Antibody detection when you are doing the test. So you can see this graph, HIV RNA plasma. So the first one is the HIV RNA that comes, okay. By 10 days to 11 or 12 days it comes. Then you can detect this by HIV RNA testing. This is the test which is done in the, in the newborns. You can do this test, HIV RNA. Next is the HIV-1 P24 antigen. This is another test which is also done in the window period. So these two tests can be done in the window period. RNA test and the P24 antigen. Okay. This P24 antigen is detected by the 4th generation ELISA. And next graph you see here, the antibodies which is rising slowly. So this is the days. They have plotted a graph as 0 to 720 days and so on. So the antibody comes quite later on. Okay. So next is P24 antigen is very important. Keep in mind, it can be asked in an exam. Okay. P24 antigen, when it is detected, 1 to 2 weeks after HIV infection, confirms HIV diagnosis, detect HIV during the window period, diagnose HIV in the infants. Key aspects of early HIV detection and prevention. So very important is how early you can detect them. Transmission prevention, it will help. Individuals with early treated and suppressed HIV cannot transmit the virus to the partners. So important, see. If we put him in medications, so it is so vital. Optimal health outcomes, immediate treatment preserves immune function and significantly improves the quality and length of the life. High pre-ART viral load and a low CD4, okay, count indicates a higher risk of disease progression. So CD4 count is the count that we use for monitoring the prognosis of the disease or for the ART treatment, whether he is really responding it or not. While effective ART should lead to a low or undetectable viral load and higher CD4 counts. Targeted screening is routine testing is recommended for individuals with high risk behaviors, including multiple sex partners and protected sex or sharing of the needles. This sharing of the needles, I want to tell something. Why it is increasing more in Tripura? This is my thought. Because you cannot go and buy a needle. आप जाओगे तो needle आप खरीद नहीं सकते हो. So if you cannot buy a needle, so then what they will do? They will share it, right? So that is one drawback. So stopping transmission in mother to child, early diagnosis and treatment are crucial for pregnant women to prevent passing the virus to the infant. Earlier the better. So window period is time between HIV exposure and detectable antibody levels in the serum. P24 antigen detection possible within 1 to 2 weeks after exposure. HIV viral RNA detection, most sensitive method, detects virus as early as 10 to 12 days. This is all repetition. I did it because I wanted to emphasize these are so important for exam purpose also. Okay, and also for diagnosis purpose. So that's how I wanted to finish it up fast. so because we have more people to talk. So please be attentive and try to absorb as much as you can, because it is we have tried our best to put an integrated class, and use it, your knowledge, use it for your patients when you go in the wards, in the clinics, you know, that will make you much more wiser and also help you for your exams. Thank you. So.
A very good afternoon to everyone. I am Dr. Momana Dash, Assistant Professor in the Department of General Medicine. HIV itself does not need any introduction. We are all aware of this virus, right? So we are here to have an integrated session on HIV. So as it is a very huge topic, so it is practically impossible to cover it within a span of 30 or 40 minutes. So I shall be moving towards the clinical spectrum and the management part, okay? So first of all, why should we learn about this virus? What is so special about this virus? As ma'am has already discussed, that is because of the high burden of the disease. That is, globally around 40.8 million people are affected with this virus, and India has an estimated more than 2.5 million people that are living with the virus. Now, before moving towards the clinical spectrum, we should know about the routes of transmission. I am pretty sure that everyone knows how the disease is transmitted. So, most important, it is the blood transfusion, which has got more than 98% transmission rate, followed by perinatal, okay? And here in this slide, I want you people to focus on this particular needle stick exposure, okay? As you can see here, after a needle stick exposure, the rate of transmission of HIV is only 0.3%, whereas the risk after needle stick injury for hepatitis B virus is around 9 to 30%, followed by the hepatitis C virus, that is 1 to 1.8%. Okay, so you can see that after an unfortunate needle stick exposure, we should be more concerned about contracting hepatitis B virus than HIV. Now, coming to the clinical features, HIV involves each and every system of our body, starting from head to toe. Each and every organ is affected. So, the clinical features depends on the stage of infection, okay? In the initial few weeks after getting the infection, the patient may be asymptomatic, or they can present with some influenza-like illness like fever, sore throat, anorexia, decreased appetite, just like that, okay? But as the infection progressively weakens our immune system, then the actual signs and symptoms appears, okay? So based on the opportunistic infection that we will be learning later, the WHO has categorized it into 4 clinical stages, okay? So before moving towards the clinical stages, around 50 to 70% of the individuals with HIV infection experience an acute clinical syndrome 3 to 6 weeks after the primary infection, and this is known as the acute HIV syndrome. Here, along with the symptoms like fever, pharyngitis, lymphadenopathy, headache, myalgia, arthralgia, the patient might present in an emergency neurological state, that is the meningitis, encephalitis, peripheral neuropathy and myelopathy. And there may be some skin lesions as well, like erythematous maculopapular rash and mucocutaneous ulceration. Okay, so this is all about acute HIV syndrome. So in the clinical stage 1, the patient may be asymptomatic, or the patient might present to you with certain generalized lymphadenopathy. In clinical stage 2, the patient will present to you with weight loss, but it will be around less than 10% of the presumed body weight, okay, along with some herpes zoster or angular cheilitis or recurrent oral ulcerations. In the clinical stage 3, you will be getting weight loss, but this time the weight loss will be more than 10% of the measured body weight. Along with that, you will be getting oral candidiasis, then oral hairy leukoplakia, pulmonary TB, then severe bacterial infection, acute necrotizing ulcerative stomatitis or unexplained anemia. Now coming towards the advanced stage of the disease, okay. So here all the opportunistic infection that you might know is included under this clinical stage 4, okay. Here we will get HIV wasting syndrome, pneumocystis carinii pneumonia, then chronic herpes simplex infection, esophageal candidiasis, Kaposi sarcoma, CMV infection, extrapulmonary TB, then progressive multifocal leukoencephalopathy, and so on. So, ma'am has already described to you whom should you test and whom should we treat. These are the priority population that are included under HIV counseling and testing strategy. These are the patients mostly high risk group population including prison and other closed settings. Then the self-working clients with risk behavior, then social and sexual networks of self-initiated individuals, HIV negative partners of the people living with HIV index case, then at risk youth and adolescents, then HIV exposed babies and the pregnant women. So these are the priority population under this strategy. Now after completing the clinical spectrum, I am moving towards the management part. Management includes positive cases. Okay. After that, we have to take a proper history and do the general physical examination as well as the systemic examination. Okay. Next, we have to find out the possible risk factors associated with acquiring HIV, like whether the patient is having TB or syphilis. Okay. Next is possible opportunistic infections that the patient might have. Okay. Next is the comorbidities like type 2 diabetes mellitus, chronic kidney disease, chronic liver disease. We have to find out all the comorbidities. Next is what is the vaccination status of the patient, whether the patient is vaccinated towards hepatitis B or not, just like that. Next is whether the patient is pregnant and the socio-economic condition of the patient. So these are some of the oral lesions. As you can see, the first picture shows an oral thrush that is caused by the candida. Here you can see some cheesy exudates that are present over the posterior pharynx. As you can all see, right? So this is an oral thrush that is caused by the candida. Second picture is that of oral hairy leukoplakia. Okay, here you can see some whitish frond-like structures in the lateral side of the tongue. So these are the oral hairy leukoplakia that shows that there is increased incidence of Epstein-Barr virus. Next, you can see some punched out lesions here. So this is the painful aphthous ulcers. And the last, it is the picture of Kaposi sarcoma. Kaposi sarcoma is a low-grade vascular neoplasm that is caused by herpes HHV8. Okay. As your microbiology classes are over, so I assume that you people know about the structure of the virus, how it enters the cell and causes replication and all. Am I right? Because it is very much related to the treatment part. Here you can see that how the virus is entering into the cell and replicating. So the antiretroviral drugs, the category of the drugs, they inhibit or they stop each and every step of this cycle. Okay. First, we all know, first of all, the virus enters into the cell. To stop that, there are three classes of antiretroviral drugs that are acting. One is, you can see, CCR5 co-receptor antagonist. This is the maraviroc. Second, here you can see some fusion inhibitor. It is the enfuvirtide. And the newly diagnosed antiretroviral drug, that is the fostemsavir. It is a glycoprotein 120 inhibitor. It inhibits the glycoprotein 120. So these three classes of drugs, they inhibit the virus entry. Okay. Next is the reverse transcription phase, where the viral RNA gets modified into the viral DNA with the help of reverse transcriptase enzyme. So here the nucleoside reverse transcriptase inhibitor, non-nucleoside reverse transcriptase inhibitor and the nucleotide reverse transcriptase inhibitors, they all inhibit this step of the process. Next is what happens, it is the integration of the virus. The viral DNA then integrates with the host DNA. This process is inhibited by the integrase inhibitor. Okay. Next, this transcription and translation occurs and thereby viral proteins are formed. Then this cleavage, assembly, budding and maturation, and thereby release of the mature virion occurs from the cell. And these three steps are inhibited by the protease inhibitor. So this is how the antiretroviral drugs are working. Okay. Next, these are the names of the antiretroviral drugs. One is the nucleoside reverse transcriptase inhibitor like zidovudine, lamivudine, abacavir, didanosine. Then the nucleotide reverse transcriptase inhibitors like tenofovir. Then non-nucleoside reverse transcriptase inhibitors like nevirapine, evavirins, then doravirine. And integrase inhibitors like dolutegravir, raltegravir, cabotegravir. Cabotegravir is newly synthesized. Now fusion inhibitors like enfuvirtide. CCR5 entry inhibitors like maraviroc, protease inhibitor like ritonavir, indinavir, lopinavir, atazanavir. And these are the two newly approved drugs. This is the post-attachment maturation inhibitor ibalizumab and fostemsavir. As I have already told you, it binds to the glycoprotein 120 and prevents the viral attachment to the CD4 plus cells. Okay. I know it is very difficult to remember it now, but with due course of time, you will be able to know that. Now, we have to start the ART as soon as possible. We should not wait for CD4 count and all. If the patient is diagnosed with the HIV, you should straightforward start with the ART. Enroll the patient in any ART center and counseling to be done prior to the drug therapy. Okay. And the first line ART that is given, it is the tenofovir 300 mg, lamivudine 300 mg and dolutegravir 50 mg. It is given as a fixed drug combination once a day. Now, there are certain conditions where you can't give this regimen, this first line ART. Here comes the role of the second line ART. This is whatever I have told you, tenofovir, lamivudine and dolutegravir, you can use it in a patient who are more than 30 kg at least. But in patients who are less than 30 kg, you cannot give tenofovir. In that case, you have to give abacavir. Okay. Second special situation is the patient is having CKD with an increased serum creatinine. Here you have to find a creatinine clearance first. Then in place of tenofovir, you have to use abacavir 600 mg and you have to titrate the dose of lamivudine. But dolutegravir you can give. Okay. Third special situation are if the patient is HIV positive, along with that the patient is on rifampicin containing ATT. What rifampicin does is it increases the metabolism of what? Dolutegravir. So you have to give tenofovir, lamivudine, dolutegravir, but along with that you have to give an extra dose of dolutegravir, 12 hours, okay, until 2 weeks post ATT. The fourth special case, it is the women of childbearing potential, those who are not willing to get this dolutegravir. It has been seen that dolutegravir may cause neural tube defects, but the recent studies have shown that these are negligible, okay. So if the patient still doesn't want to take dolutegravir, then you can give efavirenz in place of dolutegravir. Another special case is that in such case, the efavirenz is contraindicated, such as the patient is HIV-2 positive or prior non-nucleoside reverse transcriptase inhibitor was used. So in that case, in place of dolutegravir, you can give lopinavir, ritonavir combination. Okay? Okay. So, as a physician, after giving the drugs, you should know what are the adverse effects of the drugs. Okay. So, these are some of the few adverse effects that we should know. That is, tenofovir can cause renal dysfunction, whereas among the tenofovir, TDF, that is the tenofovir disoproxil fumarate, it causes more renal dysfunction, whereas the tenofovir allofinamide causes less renal dysfunction. Then bone demineralization is also caused by tenofovir. Zidovudine, it causes bone marrow suppression and nail hyperpigmentation. Why should we know about this adverse effect? Because you are giving the drug for a longer duration. Okay, so you have to monitor the patient. You have to do CBC, LFT, KFT. Why? Because these drugs are causing those adverse effects. So we have to monitor the patient. Okay. So dolutegravir, it causes myopathy, weight gain, poor glycemic control and dyslipidemia. Abacavir causes Stevens-Johnson syndrome. It is an emergency. Okay. Efavirenz causes hallucination and sleep disturbances, and nevirapine causes hepatitis and skin rash. Now you have prescribed the medication. Now you should know how to monitor the patient. Monitoring means first you should know about the general well-being of the patient, how well the patient is doing. Second is the CD4 count. First CD4 count should be done at the baseline. Then we have to do it every 6 monthly until the CD4 count is more than 350 and the viral load is less than 1000. So our target is CD4 more than 350 and viral load less than 1000. Okay. Next is the viral load. Our target is less than 1000 copies per ml for sustained virological response. And lastly, whatever I was telling you, that we should do regularly CBC, LFT, KFT, lipid profile and hepatitis B serology annually in the people who are very much prone to get this infection. Just suppose the patient is not hepatitis B vaccinated, or the patient is not willing to take hepatitis B vaccination, or the patient is a drug abuser. So in such case, you have to do hepatitis B serology once in a year. Now, we have treated the patient, we have given the medication, we have monitored the patient, still the treatment is a failure. So, what are the parameters? First is the clinical failure. That is, the patient has developed new WHO stage 4 condition, whatever opportunistic infections I have already told you, after 6 months of ART use. Second is the immunological failure. Immunological failure means the fall of CD4 count to pre-therapy baseline value. I have already told you the CD4 count is done at the baseline, then it is done repeatedly at 6-month interval. So, if the CD4 count falls to the pre-therapy baseline value, then it is considered a failure. Or if there is a 50% fall from the on-treatment peak value. Or if the persistent CD4 count is less than 100. You are giving ART, the patient is taking, but still the CD4 count is not more than 100, then you can consider it as a treatment failure. Next is the virological failure. That is, the viral load is more than 1000 copies per ml. Okay. Now, before starting the ART, you should be aware of certain syndrome, that is the immune reconstitution inflammatory syndrome. In short, it is known as IRIS. What happens is that the patient is also already having an infection, you are aware of that, okay? But you have started the ART, and after initiation of the ART, there is worsening of, okay? So this is known as paradoxical IRIS. In the second scenario, you are not aware of any illness, but the patient is having an occult infection. You have started the ART and there is an abrupt appearance of a new clinical findings. This is known as unmasking iris. So we can get paradoxical iris or an unmasking iris. So it mostly occurs 2 weeks to 3 months following the initiation of ART. It has been seen if we start the ART at CD4 count less than 50, there is more chances of iris. If there is high initial viral load, if there is rapid fall in the viral load, or the patient was having an opportunistic infection, and the young age of the patient, or the genetic susceptibility. So these are the risk factors that leads to iris. Now, as an healthcare worker, as a medical professional, we should know how to deal with a needlestick exposure. Okay. So this is the first aid for an occupational exposure. First of all, we should not panic. Okay. Second is that the post-exposure prophylaxis should be started within 2 hours, and maximum 72 hours you can start it. Okay. But preferably we should start it within 2 hours. First is, if there is a if the skin is pierced or there is a loss of skin integrity, then we should wash the area with soap and water. No alcohol, no chlorine, no bleach, nothing should be given. Okay? Just wash the area with soap and water. If there is an exposure over the eye, then you should irrigate the eyes with only water. No disinfectant, no soap. Okay? If the patient or the person is wearing lens, then you should keep the lens at its place. You should irrigate the eyes. After complete irrigation, then you can take out the lens and can do the disinfection part. Okay, so this is the first aid that can be done. Then you should give the patient post-exposure prophylaxis. Okay, I know this is a very busy slide, but one thing I want to emphasize is that only if there is a disruption in the mucosal integrity and the amount of exposure is very little, then only you may not start PEP. In rest of the cases, you should straightforward start the post-exposure prophylaxis for 28 days. And the post-exposure prophylaxis is same as the first line ART, that is the tenofovir, lamivudine and dolutegravir, which is given for 28 days. There are some alternate regimens, like you can give lopinavir, ritonavir in place of dolutegravir, or you can give efavirenz. Okay, but the preferred one, it is the tenofovir, lamivudine and dolutegravir. Now we have to follow up this patient who has got a needlestick exposure. We have to monitor the patient for acute seroconversion, avoid blood donation, breastfeeding and pregnancy. Then we should adherence and adverse drug reaction counseling to be done, and the patient should be tested at 6 week, 12 week and 24 week for the acute, to detect the acute seroconversion. So we have to do HIV antibody at that time, at this 6 week, 12 week and 24 weeks. Now HIV discussion is not over unless we talk about the opportunistic infection. Normally the opportunistic infection means the infection that happen when there is immunosuppression. It occurs due to immunosuppression in HIV. It does not occur in immunocompetent individuals. Usually when the CD4 count falls below the critical level. There is impaired cell-mediated immunity that leads to reactivation of the latent infection and new opportunistic pathogen. What are the common opportunistic infection? At CD4 count less than 500, the patient might encounter tuberculosis, bacterial pneumonia, herpes zoster. At CD4 count less than 200, the patient might have pneumocystis jirovecii pneumonia. At CD4 count less than 100, the patient might be exposed to toxoplasma cryptococcal meningitis. And in CD4 count less than 50, the patient might contract CMV and the Mycobacterium avium complex infection. So these are some of the preventive measures that can be taken. First is the Mycobacterium tuberculosis. If we do the Mantoux test and if the lesion is more than 5 millimeter, then we can start the patient on isoniazid. Or if the patient is having positive interferon gamma release assay, then also you can start the patient on this prophylaxis. If the patient is living with the person who is active pulmonary TB case, then also we can start the patient on isoniazid. Second is the pneumocystis jirovecii pneumonia. If the CD4 count is less than 200 and there is RNA virus that is detectable, then you can start the patient on trimethoprim sulfamethoxazole. If the CD4 count is less than 100, then you have to start it straightforward. Or if the patient has previous incidence of pneumococcal pneumonia, that is pneumocystis jirovecii pneumonia, then you can start the patient on trimethoprim sulfamethoxazole prophylaxis. Next is the Mycobacterium avium complex. Here you can give azithromycin 1.2 gram. Then toxoplasma, for toxoplasma we can give trimethoprim sulfamethoxazole. Foster we can give immunoglobulin. For cryptococcus you can give fluconazole, and histoplasma itraconazole, and lastly cytomegalovirus valganciclovir. So this is a list of all the complications. Ma'am has already described to you what are the, as I have already told you in the initial few lines of my presentation, that the HIV virus can affect each and every system of our body. This is what I was telling you. Okay, it can cause opportunistic infection, malignancies like Kaposi sarcoma, non-Hodgkin's lymphoma, invasive cervical cancer, anal cancer. Then in the neurological, HIV-associated neurocognitive dysfunction, HIV encephalopathy, peripheral neuropathy. In the gastrointestinal system, it can cause chronic diarrhea, esophagitis, hepatitis B and C virus co-infection, and cholangiopathy. In the respiratory part, it can cause pneumonia, TB, bronchiectasis. In the cardiovascular part, it can cause dilated cardiomyopathy, pericardial effusion. In the renal, it can cause HIV-associated nephropathy, immune complex glomerulonephritis. In hematology, it can cause anemia, leukopenia, thrombocytopenia. In the metabolic and endocrine part, it can cause wasting syndrome, dyslipidemia, and insulin resistance. Such an exhaustive list. Okay, so it means it can affect each and every system of our body. That's all about my presentation. I hope I have given you an overview of the clinical spectrum and the management part. The rest will be dealt in our medicine classes. Okay, thank you.
So they have an immature immune system. That is why what we will see, if our defense system is bad, any country can attack us, right? So opportunistic infections are much more common, faster and dangerous in case of pediatric population. So what are opportunistic infections? We have already known that from the medicine lecture. So the recurrent invasive bacterial infections are more. Disseminated CMV infection is more. We'll see more amount of candida, HSV, varicella infection and CNS infections. So that is why in pediatric population HIV is different from adults. So clinical assessment and history is very important. We need to know at which stage of illness we are getting the child. So that is why it is more important, number one. Number two, why it is more important? Because we need to know if there is any progression of the disease or how our treatment is responding in case of the condition. Also, we need to identify any HIV related illnesses that may require treatment. And also we need to rule out any opportunistic infections. So active opportunistic infections have to be treated first before we start with ART. Last but not the least, to know the nutritional status and needs. So this is the kind of severe wasting we see in case of a stage 4 disease. Okay? So just rightly, a child will get the infection via vertical transmission. So what do you mean by vertical transmission? That is from the parent to the child. So we need to prevent. Treatment is not the first motive. Our first motive is prevention. So in case of children, we need to focus mainly on PPTCT, which is prevention of parent to child transmission. So in this, there are 4-pronged strategies that we use. So I don't know how many of you have read this in PSM, the 4 stages and levels of prevention. Primordial, primary, secondary, tertiary. Have we read that part? Okay. So this is what it focuses on. Okay. The first prong is primary prevention of HIV. That will be happening in general population because disease is not there, but we need to prevent that from happening. So any HIV negative. So if you just focus on this photo, the first lady, and see what's written down. It's written HIV negative general population. So we need to address them via how? ARSH. So adolescent reproductive and sexual health. So this is how we approach them. So whenever you will go to a gynecologist or you see a paper or a report of a gynecologist, you will see that HIV, HCV, HBsAg, baseline investigation, all gynecologists will do before it, or a surgeon will do before any sort of procedure because of this. So this is the first prong of PPTCT. The second prong of PPTCT is in case of preventing any unintended pregnancy. So that means we are doing in a HIV positive mother, HIV positive female, so that we can provide her ways so that a child having an HIV positive status can be prevented. Wow, how? We need to offer family planning services to her. So here this is where ICTC, the Integrated Counseling and Testing Centers come, and also most importantly the ART centers for any female who is non-pregnant but HIV positive. Come to the third female. Third female, she's prevention of mother to child transmission. She is HIV positive, she is pregnant. So here, this is the third prong. The last is, we have tried all those three things. We have still not been able to prevent. The last female is about care, support and treatment for an HIV positive mother, the HIV positive child. Okay? So are we clear how the prevention works? Are we clear with it? So here comes ARV prophylaxis. So what we are going to do with the mother, you will know when you go for like medicine classes and also for your gynecology. But in case of children, how do we prevent it depends on prophylaxis. Even before we know, just like ma'am said, in a little baby, it is not easy to detect. Any child who is less than 6 months, it is not easy to do the normal testing. We need to see RTPCR. Okay? And it is a cumbersome process. Until then, we cannot stop ourselves. So, ma'am, till 6 months, what are we going to do? We need to give a prophylaxis antiretroviral. So, ARV is your antiretroviral or the anti-HIV drugs. Okay? So, how do we differentiate which baby and what and till which time? Okay. So, here please focus on this. There are two boxes. We have a high risk infant and we have a low risk infant. So, a low risk infant, the first one is any infant that is born, that is basically going to be born to a mother who has a low viral load. How much? Less than 1000 cells per ml. Number one. Second is the baby is born after 32 weeks of pregnancy. Am I clear? 2 pointers only. Mother has low viral load. Number two, baby is more than 32 weeks at the time of termination. That is a low risk infant. So a low risk infant, what are we going to do? The treatment option, we have syrup, nevirapine. Okay. How much are we going to give? Till how much? That is separate. But we need to know that the option is syrup, nevirapine. Okay. So focus on the slide. You will be understanding it better. So in case we cannot give nevirapine, the second option is syrup, zidovudine. In which cases, any HIV-2 infection, any mother with both HIV-1 and 2, any mother who has already gotten nevirapine in her ART before delivery or in the earlier part of pregnancy, and infant born to a mother who is on protease inhibitor based ART regime due to treatment failure. For how long are we going to give? Duration is from birth, the day 1 of birth till 6 weeks of age. This is the prophylaxis for a low risk infant. Clear? Next part of the box will come, which is the high risk infant. So any infant that is born to a HIV positive mother not on ART, very high viral load, less than 32 weeks, and also a mother who is newly identified as HIV and positive within the first 6 weeks of delivery. Okay? So here the treatment will be different. How are we going to treat them? We are going to give both. Okay, option nahi hai. We are going to give both. We are going to give both nevirapine and zidovudine, and the duration will be longer. Okay, what is that? That is in case of exclusively replacement feeding. We'll come to that. Till birth to the 6 weeks, if the baby is on breastfeeding, then we are going to give till 12 weeks of age. Is this slide clear to everyone? Okay. So, diagnosis at an age which is less than 18 months of age of a baby, that is again divided into two parts. Because less than 6 months, so 8 point, so in a paper, please write this one point. Less than 6 months, we cannot do any sort of ELISA or any sort of test like those. We need to detect RTPCR. HIV has to be detected. So we need RTPCR testing for that. This is a Viva question for you. So another Viva question for you is P24. Read it properly for your microbiology also. So see, what are we going to do? Less than 6 months, we need to get a dry blood sample. How we take a dry blood sample? We can take it by heel prick or pricking a baby. So we detect the HIV, we double test it again for HIV-1 PCR, and then finally we detect and we start on ART. Yes, ma'am.
See, this HIV may not be very much asked explaining you so many things repeatedly. Many important points are told here, so be mindful here. Many questions will be asked in our life. It's a very pet topic for HIV. Okay? Pay attention.
So any baby more than 6 months, we can detect it, the antigen antibody testing. So again, we can use the serology testing here. The same protocol will be done for how ma'am has shown, that level 2, level 3. Okay, it will be like that. But in case of a less than 6 month baby, it will not be the antibody or the serology testing that we know. The next is beyond 18 months, we're going to recap what we know. So we need to use any commonly used rapid tests which are based on principles of enzyme immunoassay, which is ELISA, or immunochromatography, immunoconcentration, and particle agglutination, having a sensitivity and specificity is very, very high. Okay? And also all samples which are reactive in the first test should undergo a confirmatory test, second and third test, based on the principle or the antigen being used. Am I clear with that? It's just a recap of what already been told. Last but not the least, for indeterminate test, we repeat it after 28 days, or we call them after like 28 days. Okay? So final testing of HIV exposed infants. So HIV exposed infant, we have already seen low risk, high risk, how we change them. And for them, all HIV exposed children should undergo the HIV antibody test for definitive diagnosis. Okay? Using all 3 serological tests at Integrated Counseling and Testing Center, which is ICTC, at 18 months of age, and 3 months after cessation of breastfeeding, whichever is later. So now breastfeeding can go beyond 18 months, right? So we need to do it at that point of time. We need to ask the mother, you need to stop the breastfeeding. After 3 months, we will do the confirmatory test, and we are sure if your baby has HIV or not. Before that, it is not advisable to even say anything. Okay? So if you see the risk of parent-to-child transmission, just look at the percentages. Okay? So any mother who is not on any drugs, breastfeeding the baby, the risk is how much? 30 to 45%. But if you see any mother, the last slide you look, a mother is on 3 antiretroviral drugs, no breastfeeding, the risk becomes 1%. So this is what is written. But there is a controversy. Then ma'am, should we just tell them not to take breastfeeding? We'll come to that point. So care of an exposed infant or a child. So exposed infant is a mother who is HIV positive. So the care starts from the delivery room itself. So as a neonatologist or as a pediatrician, as an intern, when you are posted in a peripheral setup where you have very limited amount of resources, you need to know the HIV status of a mother irrespective of the place. Why? Because the care starts in the labor room. How? These are the immediate care at birth. So these 4 points, which are number 1, you need to follow universal precautions, which is no double gloves, single gloves. When you are handling the baby, you know what is milking the cord? When you clamp the cord, before that you just milk, like if it's a cord, we just milk it and take the excess amount of blood inside the baby. That can also provide extra amount of hemoglobin. So we need to stop that. We need not do that. Whatever is inside the baby, let it be. No milking of cord to be done. Okay. Next is the clamp cord. The cord should be clamped right after birth. So when you go to gynecology, you will learn about the active management of 3rd stage of labor, which says delayed cord clamping by 1 to 3 minutes. Why? You know what is cord clamping? How many of you know what is cord clamping? Then I can proceed. Only you know what is cord clamping. Nobody else knows what is cord clamping? Okay. You know what is umbilical cord of a baby? You know you need to cut that when you take the baby out. So before cutting that cord, you need to clamp it. Clamp matlab usko, we need to close it, right? With a blue color thing you will be seeing in the baby's tummy. That is a cord. That's a clamp. So before that clamping, most of the WHO protocols say we need to delay cord clamping. Why? Whatever extra blood the baby can get, we need to give the baby. So the clamping should be done after 1 minute, 1 to 3 minutes roughly. Okay? But in case of HIV, we do not do that. We need to do an immediate cord clamping. Okay? Last but not the least, initiate breastfeeding as soon as possible within the first hour of birth. Now, this is a controversial question. You will be like, ma'am, if we don't give breast, so 1% risk is there. But in a country like India, we cannot afford to not give breastfeeding to our baby. Why? Because it is a resource limiting setting, affordability is an issue, accessibility is an issue. So we need to think of the number of deaths due to malnutrition rather than HIV. Malnutrition will kill the baby within first 6 days also. But HIV is a long shot. So thinking about the greater good, we tell you can initiate breastfeeding. Okay? So counseling should begin in the antenatal period. Any mother who, so what happens here is whenever there is an antenatal period in a mother who is HIV positive, they will come to you as a doctor. They can come to you for counseling. Okay, ma'am, what am I supposed to do? Am I supposed to like breastfeed the baby or not? You need to provide them with data. Okay, ma'am, if you go for exclusive breastfeeding, this much is the percentage. If we go for exclusive replacement feeding, which is formula, whatever lactogen and prenan and all those you see, those are all replacement feeding, right? What is the risk? So the mother has to choose before the birth of the baby. Am I clear? So here breastfeeding is the preferred choice in a developing country as it maximizes the chances of survival. This is the second line of the sentence that you have. Next, mixed feeding. That is, most of the time we tell normal mothers, you give breastfeeding as much as the baby wants, but you give formula also. That is kind of a mixed feeding that we are talking about. We should not practice that because we have to cut the source of infection as early as possible. So for a baby, it is the breast milk. If it is possible that we can stop that, we need to encourage to stop that. Okay? So here is the benefits of exclusive breastfeeding versus exclusive replacement feeding. So exclusive breastfeeding, of course, we know the benefits. It is readily available, no preparation, safe to be given, not safe to be given, easy to be given, affordable. But the disadvantage being it is risk. It has risk. Okay. Also, other family members may be involved. So apart from that, as long as the baby is breastfed, there is risk. But in case of the exclusive replacement feeding, the advantages being what? The advantages is there is no risk of HIV transmission. Okay, and the mother can take help from other people also. Okay, if I am not able to do it, somebody else can help. But what are the disadvantages? Expressing of the obtaining appropriate milk water, that has to be considered. Okay, so before you start with ART, as you've already seen, we need to do a few things. That is, we need to rule out any active opportunistic infection, and also we need to see what is the clinical stage of the patient. Okay. So ART in children should be initiated as early as possible. It should not be delayed. And also we have these particular drugs. Okay. So as we have told, it is divided in terms of age and weight. So just look at the three boxes, last three boxes. First box, age less than 6 years, body weight less than 20 kgs. Drug of choice is abacavir, lamivudine and lopinavir or ritonavir. Okay. Only this much you need to know. The last one you see, age more than 10 years, body weight more than 30 kg, same as adult. Okay, it is TLD, which is tenofovir, lamivudine and dolutegravir. In between, it is again in place of tenofovir, it will be abacavir. So this is the three things that we need to know. Monitoring wise, body weight, we need to monitor every visit. Then clinical monitoring of T staging every visit. Last, the most important two things that you need to monitor, which is CD4 count and viral load. That has to be done CD4 every 6 months, viral load at 6 months, 12 months, and then every 12 months. Am I clear? These last 2 points are very important. So immunization, a baby born to you, irrespective of mother is high risk, low risk, BCG should be given. In case the baby has missed BCG immunization, who are receiving ART, it may be given once they are clinically well and immunologically stable. Live vaccines should be avoided in case of severely immunocompromised, but rotavirus is given. Okay? PCV is given and hepatitis B also as a 4-dose regime it is given. Okay? Vitamin A supplementation should be as per the immunization schedule. That's all. So among this, just remember what all doses we have talked about, which is very similar to the adult one. Okay?
Thank Department of Microbiology to give me the opportunity to speak about the psychiatric aspect of HIV/AIDS. The previous 3 sessions are very much informative, and I know you must have been like quite exhausted right now. So currently in this session we'll be discussing mostly about case scenarios, how to deal with the psychosocial aspects of people diagnosed with HIV/AIDS, how to practice empathy and so on. Okay, so I will be giving it is a participatory session, so please participate. So I will be giving 3 case scenarios. Okay, 3 persons, Mr. X, Mr. Y and Miss Z. So Mr. X is a bank manager who is recently complaining of abdominal pain. He went to a surgeon, and when one ultrasonography was advised, it was found that he was having gallbladder stones. Okay, so he was suggested surgery, and so the pre-surgical workup was done, and while the workup was done, he was found to be HIV positive. Okay, and so he went through all the procedures like the 3 strategies, and it was confirmed that he is having HIV positive. Okay, he can remember that a few years back he had a road traffic accident, following which he had a blood transfusion, and it was the probable case of transmission. Okay. In the second scenario, Mr. Y, he is a person diagnosed with substance use disorder, and he is a IV drug abuser. Okay, he is a young male of around 20 years, and he is addicted to opioid use. So when the use got like quite severe, then he started taking IV opioid or heroin, and when he went for treatment, he was advised same the serology profile to rule out any this one if he is suffering from HIV, Hep B or Hep C. Okay, so again on this screening panel he was found to be HIV and Hep C positive, and after all he was confirmed as a case of HIV positive. Okay, coming to the third case, that is Miss Z. She was recently having mixed period, and urinary pregnancy test came to be positive. She was very much delighted of being a mother, because the couple has been trying for like quite a long time, and after a lot of treatment she was able to conceive. Okay, now again the panel has been advised by her obstetrician, and she was found to be HIV positive. Okay, in every of the case scenarios, how the people are going to react, when they came to know that they are HIV positive. what should be the reaction? Sad, anxious, huh? Or I am having HIV, so I am a bad person. The society is going to label me as a bad person. That is social stigma. Then they are all non-medicals, so they are not aware of the prognosis of HIV/AIDS. So according to them, HIV is a very much fatal disease. Once diagnosed, they are going to die. They have watched many movies where people diagnosed with HIV had a very bad ending. They ended up contracting severe other infections and they eventually died. So second reaction will be fear. Right? What will be the reaction of Miss Z apart from these two reactions? Who is a pregnant woman and has been diagnosed as HIV/AIDS. What is going to be her reaction? She will be worried about her child. So, she'll, apart from being I am a bad person, she will be also worried about that the society will also label her child as a child of bad person. And she has heard many stories where people diagnosed with HIV/AIDS has been discriminated. Children are not getting admission in a good school. Their education is being hampered, job denied, and being fired from the job also, which is also the concern of Mr. X, who is again a bank employee, right? So these are the two most common reactions that a person diagnosed with HIV are going to have. Okay, so there comes the confidentiality part. Why it is very much important to practice the ICTC guidelines, where just after getting the result, you can declare the patient of having HIV/AIDS, rather you send the person to ICTC counselor. Here, not only about the disease, but also about the treatment part will also be explained to the patients or the persons diagnosed with HIV/AIDS about the prognosis, about the treatment and so on. Okay. Now, coming to Mr. Y, what reaction he is going to have? What reaction is he going to have? Mr. Y is a case of substance use disorder, and already his parents are very much pissed off him. He has quit his studies. He has already been labeled as a bad person by the society. Okay. Apart from it, he has been diagnosed with HIV/AIDS. What has been seen is that though needlestick injury causes very less amount of transmission, but the way the needlestick injury is happening, especially by sharing of the needles, it is quite troublesome. So, Mr. Y will be like more prone to spread the disease by sharing of needles. Because again, he doesn't want to be a worse person. So, probably he will not be discussing his status with his other friends or the fellow persons with whom he will be sharing the needles, because needles are very difficult to get. If you just go into a medical shop and ask for an insulin syringe, mostly by insulin syringe, they do this means IV drug abuse, you will not be getting so easily. Mostly they ask for a prescription, or they ask the pharmacy persons, they ask for like for what purpose you are going to give it, and they are also being sensitized, because if some young males are the like most common group of having IV drug abuse. So any suspected case, if some some young male is approaching without prescription for insulin syringe, usually the pharmacy owners, they decline it, and that is why the sharing of needle is on rise, especially in our state, because again the substance use disorder or the IV use of opioid or heroin or brown sugar is quite alarming in our state. Okay. Now, while having the initial reaction, which is also known as acute stress reaction, acute stress reaction is what? The emotional turmoil the person will be going in the initial phases, like mostly by 48 hours, it can extend up to 7 days also. And after that, like with all the counseling and help, usually the reaction may subside. But then comes the later part. For example, they may gradually develop adjustment disorder, major depressive disorder, or recurrent major depressive disorder, mixed anxiety and depressive disorder. Okay. These are the usual psychiatric cases we usually find in our day-to-day practice or in medical colleges, where people who are being under treatment or being recently diagnosed, or like they have been under treatment for a long time, the common or the usual presentation are usually this one. Now, interestingly, in the clinical stage 4, as you have seen in the medicine slide, where there are like more severe illnesses, opportunistic infections, and these occur, we get another condition known as cognitive decline or dementia-like changes. Dementia-like changes. Any idea what you understand by cognition? So cognition is the ability by which we think and assess ourselves, others, and the situation. So there are like many components in cognitive function. For example, attention span, memory, processing speed, executive and organizational function. You will see that people who has aged beyond 60 years, 70 years, they will be having some trouble remembering or learning new things. They forget where have they kept their day-to-day this one things and items. There is like impairment of the working memory. So this is known as dementia. Dementia occurs because there is like age-related cerebral atrophy of the brain, which impairs our cognitive function. In HIV/AIDS, it has been seen that the person may develop, irrespective of the age, a decline of cognitive function, which usually correlates with the viral load or the stage of the disease, right? And sometimes in very rare cases where the persons usually contract CJ or Creutzfeldt-Jakob this one disease, they may have multifocal leukodystrophy, where the persons will be presenting with dementia-like features. Okay. So these are mostly the psychiatric aspect that we deal with the patients suffering from HIV/AIDS. Another interesting one I would like to say. Who one knows about? Do you understand what is hallucination? What is hallucination? Yes, okay. So hallucination usually occurs in our, okay, sit down, in our sensory modality. So the actual stimulation is not there, but the person may perceive the stimulation. Mostly hallucination occurs in the auditory area, where I am not seeing the person, but I am hearing the voices as clear as like I am hearing yours. If it keeps on happening continuously, I will be believing that some person or a person is continuously communicating with me. Okay. There may be instances of visual hallucination, tactile hallucination, and so on. So people suffering from HIV/AIDS may also have hallucination, and there is another interesting aspect. Ideally, if the person is on having dementia-like features, then the person may have hallucination. Or there is another thing, in the treatment part, people who are getting efavirenz, they may have hallucination. This is a side effect or a rare side effect of treatment-induced hallucination or iatrogenic hallucination. So in that case, we need to revise the dosage, or we may request the treating physician to change the drug, or if possible reduce the drug to a certain amount. If we have ruled out that efavirenz is not being used, then we will treat the case as other cases we treat as hallucination. Okay. Now, practicing empathy. What do we understand by empathy? What is empathy? A simple thing. For me, you are just sitting there and relaxing. Okay? For you, I am confidently giving the lecture. But in my heart, I am scared of giving the lecture actually. Or you may look relaxed, but probably you are thinking of something else. So, I am not able to think what is happening or what you are feeling, or you are able not to see or feel what I am going through. That means when I am stepping into your shoes, or you will be stepping into mine, we will be able to understand, or we can make an effort to understand what we are going through. So that is empathy, right? Empathy, a person diagnosed with HIV/AIDS, how the society usually treats them. Bad person, they are having high risk behavior, they must be having multiple sexual partners, they must be involved in prostitution, like this. This is the common notion. But as physicians, as doctors, when you are going to treat them, if you get this judgmental or prejudiced, will you be able to treat them? Yes or no? Will you be able to treat them? Because you are not able to understand their aspect. Say for example, Mr. X, who was a bank manager diagnosed with HIV, probably he had blood transfusion from which he acquired HIV. But he will be thinking that the society will be labeling me as a bad person. They must be thinking that I must be going to the prostitutions. That's why I have contracted HIV/AIDS, right? So that is the awareness, that is the attitude of the society towards people suffering from HIV/AIDS. So now, while as treating physicians, we have to practice empathy. One thing that we have just now discussed, and Tanuja ma'am has also discussed, that needle sharing is getting quite common, and it is getting one of the mode of transmission among patients who are having HIV/AIDS. Okay. Now, I will end my session with a story here about practicing empathy. It is a true story. It is not fictional. Characters are not fictional, and nothing are coincidental. Okay. Before Tripura, Manipur was like one of the state who are having like substance use disorder in an endemic phase. IV drug abusers, HIV/AIDS, the rising case of HIV/AIDS and all. Okay. So the government, what they tried to do, as like in our state, they thought that if we cut down needle usage, and if we apply strict regulations for buying the needles, we may cut down the usage of needle and we may prevent the spread of HIV/AIDS. That was going on, but it was not helping. As like in our state, the cases were on rise. So the Department of Psychiatry from RIMS, they came up with an idea that what if we start distributing needles free of cost in some areas in booths. And they proposed the thing to the government. So the government or the bureaucrats got furious. How can you suggest such sort of stupid suggestion that by sharing needles, by giving them, you are actually encouraging people for using using needles. So it is going to the HIV/AIDS or other things, or the substance use even, these are going to rise, right? So then they have like explained that there is a concept called harm reduction technique. It is, no matter how hard you try, there will be some cases, the cases you can't help, but at least you can cut down some of the risk factors, and it is one of those. And after getting the ideas, or like convincing the government and also the other NGOs and other organizations, and even the psychiatry department went to the underground organizations also, that is the terrorist organizations, to help them. And with that help, by distributing needles and all, they were actually able to bring down this needle sharing and limit the spread of transmission. It was not able to bring it down to zero, but the numbers were reduced. Okay. So that is a practical example of empathy. To understand what they are going through, there are many other factors, like the people who are suffering from substance use disorders can't help. There may be like several psychosocial problem. They are having the problem from terrorism, unemployment, and so on. And there are like big pockets of distribution, like the junta government of Myanmar, then there the Afghanistan. Like no matter how much the government try, there will be always infiltration of drugs in those areas. Cartels are active, okay? But by this method, they are able to cut down or bring down the percentage of spread from sharing of needles. That is empathy. So I will be giving you a homework. Homework will be try to find out something about empathy. empathy, how empathy can help people suffering from HIV/AIDS. Okay, so I'll be concluding my lecture. Thank you once again.